Good morning! Welcome, my internet friends, to the Medicare Cafe pre-chat. We're starting here just a little bit early, a couple minutes early, in fact, just to kind of talk about. It's been utter chaos in the studio,
sure.
and it's my favorite part of Medicare Cafe. It's just the crazy conversations that happen before that. We'll get started here at the top of the hour. If you're watching the recorded version of this, just fast forward like 2 minutes. If you're just like, I don't want to hear about your chaos, about Chalen's voice being being the sound of the Terminator. We'll get to that. If you're just like, I just want the dirty facts, then please fast forward a couple minutes. But for everybody else, this is my friend Chalen. You know him, you love him. I'll do the formal introduction here in a little bit. But we were talking about AI, the use of artificial intelligence. I just got a notification that Integrity's Ask Integrity on the Medicare Center platform won the 2025 Artificial Intelligence Excellence Award, which is really exciting. We were talking about how artificial intelligence gains its intelligence, and Chalen said, in your voice, which is my favorite.
Yeah.
What did you say?
So Alex was in here talking about running audio through AI and using it to process things. I said, well, I'm sorry if someday your voice is now the voice of the Terminator robots that are inevitably coming down the line. And I just said, man, how incredibly upsetting would it be for someone to look up and be killed by a Terminator with my voice?
Like, I'm trying to think of what they would even say. Are you ready? Hold still. Anyways, that sounded creepier than I meant for it to. But like, you do have such.
I actually said it.
Right. You have such a radio voice. It's just so calming and even keel. And I'm over here just like a spaz. Like the definition of a spaz. You complete me. Truly. Guys, welcome to the Medicare Cafe. Again, you are joined by your host. As always, my name is Olivia Richardson.
And I'm Chalen Jackson.
And I'm excited again to have Chalen on the show. Chalen's been a frequent flyer on the show lately. You'll continue to see him because I think for those of you who don't know Chalen, Chalen is truly industry known, has spoken at a ton of events, including Medicarians and other nationwide events. You're currently president of our NABIP chapter for Missouri, and is continuing to climb the ranks of NABIP. So to say that you are incredibly connected is like an understatement into what's going on. And for those of you who don't know, I know Chalen would never say it on himself, but Chalen was actually a major factor in kind of saving our industry and being a factor in getting the stay and what happened whenever they were trying to cut out hierarchies. And they said with Medicare Advantage plans no longer having hierarchies, just the agent gets paid, nobody above the agent. So Chalen's a big deal, okay? He's a big deal. Trust me. So Chalen, today, and am I running... guys, we got this. We've only been doing this now for a couple years, and I'm going to touch. Ha Today, this is what Chalen and I are going to be talking about. We're going to be talking about news from the Hill, what's going on in the Capitol. Then we're going to be talking about one of my favorite segments, which is Rumor Has It. Like, hey, we're going to talk about, maybe give some context to some rumors or dispel them. In this case, the rumors are true. Yeah. And then number 3, we're going to talk about the final ruling. And I think you said it perfectly in a video that Senior Marketing Specialist published this week. Me, talking about kind of like this is kind of the first year in a long time that it isn't so important about what they said, but what they didn't say. So we'll get into that a little bit more too. If you are watching this or watching the recording of this, feel free to text that number. That is me. I do answer your text live. And if you're texting during the recorded version, I always try to answer within 24 hours because I want to be your friend. So shoot me a text. Or if you have a YouTube account, you can also live chat us during the show. We'll pay attention to that as well. Shout out to Sadie for our new Medicare Cafe art piece.
Isn't that nice?
This is my favorite thing that exists. Okay, let's get into it. Let's talk about news on the Hill. Today we wanted to talk about specifically the Part D redesign final guidance, and then we'll get into a little bit of COBRA, which this is exciting for sure. Chalen, kick it off with what's going on with Part D redesign.
So with the advent of the Inflation Reduction Act, we have had a ton of things in Part D that had to change.
Can you imagine you being the Terminator and killing somebody just describing Medicare stuff? Go ahead. I'm enthralled.
Horrifying. But in any case, obviously a lot of reworking that had to be done to bring Part D up to speed with the Inflation Reduction Act.
Sure.
And we've been phasing that in over the past few years. We saw the $2,000 out of pocket. We saw all of these other provisions that have changed over the past couple years, and we've still got more things to phase in. So they put out the final Part D redesign for 2026 just a couple weeks ago.
Which a lot of us are pretty scared of because the chaos of AEP in 2025, just a few months ago, was a direct result of a lot of the Inflation Reduction Act and the
Very
stress
heavily
that put on the
driven.
carrier. So, like, I hear this and my heart's just like, oh my gosh, what else is coming down? So, yeah, please.
Yeah. Well, and I would say, like, not good, not bad, just is. But the two big things that I pulled out of that were, one, we now know that next year the standard deductible for Part D is going to be $610, up from $590 this year,
Okay.
and the max out of pocket will move up to $2,100 from $2,000 this year.
Not the massive increases I would expect. That's $20 in the deductible, $100 on the move. Not the massive increases I think I would have expected.
Yep.
But this isn't like new. Like we knew that these changes were coming.
Absolutely. Yeah, we knew this was coming. I would say, if anything, the MOOP increase is maybe a little bigger than I anticipated.
Is it?
To
Okay.
raise it $100 that first year,
Yeah.
is a little bigger than maybe I
Well,
anticipated.
I
but
guess I hear
it's also
100.
not outlandish.
I hear $100 MOOP, and I guess my brain is accustomed to thinking about the max amount of pocket on a Medicare Advantage plan.
Sure.
When the industry allowance goes up $100, that's kind of what we expect. On drugs, though, that is a significant. I mean, drugs, you're looking at such a smaller portion of that medical cost. So yeah, that does seem like a huge.
Yeah, it's a solid 5% increase in
Yeah.
max out of pocket.
Okay, got
so,
it.
Not too crazy, but maybe a little higher than I anticipated. And then the other big part of it was kind of a restructuring for 2026 being the first year that these negotiated prices, so Medicare negotiates 10 drugs prices every year now, the first year of those prices taking effect.
Okay.
So kind of outlined a few of those provisions about how they're going to manage that. There's so much on the back end with pharmacy contracts and kind of this clearinghouse to establish which which prescription fills are subject to price negotiation, which ones aren't.
Okay.
And then the big thing is redesigning how payments work in the Part D program by creating the selected drug subsidy.
Okay.
So this is going to be additional money that the carriers get, or rather additional money they don't have to pay.
Yeah.
So during the initial coverage phase, so post deductible before the MOOP, right now for any drug, the carrier is paying 75% of the total cost.
Okay.
For selected drugs, meaning drugs that have undergone the price negotiation.
So this year we are at 10 drugs now.
10 drugs.
Do we know
for
what
this year.
we have gotten a list of what those drugs are?
Yep, we know what that
Okay.
list is. It's some of the greatest hits like Humira and some of those other really expensive, really popular drugs.
Okay.
A lot of autoimmune drugs, things like that.
That makes sense.
But for those selected drugs and any future selected drugs, carriers will now only be responsible for 65% of those costs instead of 75. So they're basically getting a 10% discount on what they have to pay for those selected drugs. Now, this year, 2026 plan year, when those prices take effect, maybe that's not going to be a huge win for the carriers. Their selected drugs are already drastically discounted. It is going to save plans a lot of money, so hopefully it stabilizes benefits a little bit. But let's look down the road, say 5-10 years, when we've got the top 50 drugs price negotiated. Well, if you look at it, like the top 100 drugs in Medicare account for like 85%. These are rough numbers, like 85% of total Part D spending.
Okay.
So 5-10 years down the road, if you've got those selected drugs and on top of the negotiated price, carriers are saving that additional 10%, that's a huge chunk of money back in the carriers' pockets, back into benefit design, back into benefit investment. That is really going to help, especially the MAPD plans that are already having to reinvest rebate dollars and things like that to maintain that level funding on their Part D, and don't have access to like the premium stabilization demonstration like standalone drug plans did.
Right. So when we're talking about the cost going from 75% that the carriers are responsible for to 65, just to clarify, that's not saying that 10% gets passed on the consumer. That
No,
10%
that's being
is
covered by
on
Medicare.
being covered by Medicare. Okay, that's helpful. It's a good green light for Medicare Advantage plans to see the future of it. And this is the first year in 2026 will be the first year that we actually see that going.
Absolutely.
That's incredible. That's helpful to know. What are clients going to hear about that, know about that? Is this all being done in the background?
This is all going to be background
So
stuff.
if you talked about this with a client, they're just going to be like, okay,
Yep.
doesn't mean much to them.
They will probably never know, never see it. What people should know is that list of 10 selected drugs for next year should be drastically cheaper next year.
Okay.
Now, that being said, drastically cheaper also means they're not going to run through that $2,100 max out of pocket quite as fast.
So people who reach the max out of pocket this year may not do so at least as quickly next year.
Correct.
Okay.
Correct, yeah.
Which is a good thing and a bad thing, I guess. Just expectations.
Yeah, absolutely.
Okay.
I think, what we saw was, when the IRA was redesigned, it was obviously filled with imperfections, filled with negative consequences, at least in the short term.
Yeah.
But really, in the long term, say 10 years down the road, it's a system that has some balancing to do over time. And this is kind of phase one of that balance.
So we saw, again, I think that's a really great way of saying it. People are looking at the IRA and what it did in 2025 and just people are idiots. And people on Capitol Hill have no idea what they're doing. Save your applause. And then just kind of seeing the immediate response, not really considering that long term, a lot of balance is actually going to be helping. I love that. A lot of balance
is just a prop.
This is a prop. I love these, but they are a prop. You know, some ASMR. But knowing long term within, again, by the end, when does the IRA implementation done? Is it 2036?
So drug negotiation will keep going through 2039.
2039. Okay. So knowing that when you look at it throughout the entire implementation, there we go. Implementation, the costs do kind of balance out, and Medicare Advantage plans via their Part D will get some cuts there. Get some breaks, I should say.
Yeah, and I think that's, there was a lot of talk this year about how, $2,000 is not really $2,000. We've got clients that are only paying, say, $700, and then they're hitting that $2,000 max out of pocket. And again, it's just a timing difference.
Just the timing. Okay.
As we see more of that price negotiation phase in, more of those things, that's going to become a lot more realistic number.
Okay. It is fascinating. If anybody if you come across this podcast, come across this channel, you're just this is wildly boring. But to us,
for sure.
to us though, just how it's shaping the industry and shaping healthcare access to healthcare is crazy.
It is.
So let's move on now to Cobra. So this one, I'm dying for an update. So as everybody knows, Cobra and it's considered it's consideration of credible coverage. It is credible coverage for Medicare Part D as it stands today.
Can be, yep.
But it's not, good point, but it's never going to be considered credible coverage as of today for Medicare Part B. It gets really confusing. It gets, because it is for one, not for the other. I know that has been an initiative for NABIP now for quite some time to get Cobra considered credible. Again, if it was considered credible when you were an active employee, having it considered credible when you're no longer active with that company. I didn't know there were any updates. Tell me tell me. Maybe there aren't any updates. Maybe I'm hyping you up just to be nope, it's more the same.
No, we do have some updates. So, this is something that, as you said, NABIP has been working on for a long time. There is a new bill in Congress right now to make Cobra creditable coverage for Part B.
Make Cobra creditable again?
It was never creditable. So
well, no, but it sounds better. Make your coverage credible again?
Yeah,
anyways.
Something like
that.
But so there is a bill currently there in Congress to make Cobra creditable. Now, I think the long term on this is it's always going to be a tough bill to pass. It's not a huge priority for a lot of Congress folks, but there is starting to be some rumbling, some early talk about a big healthcare omnibus that may come up this fall.
Okay.
So they may pull a bunch of health titles and shove them into one big bill this fall and try to pass it. So I think that's probably the best chance we have to get something like Cobra's creditable coverage through Congress and to the president's desk. So we'll see that along with a lot of other health titles like potentially PBM reform, potentially some of this transparency, a lot of the things that were in the health titles of the spending bill from last December that got killed off before they did do that last minute government funding bill.
Tell me a little bit about why, because when I see Cobra becoming not being credible coverage, where I see that be the biggest issue today is someone didn't know that, wasn't educated on that, and then stayed on Cobra for 6 months, 18 months,
Yep.
and then never got on Medicare. And it was simply just because they weren't educated, right?
Absolutely.
Not that Cobra coverage is better. Can you give me a reason, like, why is this so important to NABIP that somebody has the option to stay on Cobra versus going on to Medicare? When would that become applicable? When would that be a better fit for a client?
Sure. So one of the biggest reasons is just avoiding those lifetime penalties. That
Yeah.
Part B late enrollment penalty, 10% for every 12 months can be a bear for folks that are on a limited income.
Sure.
So avoiding those penalties and also not penalizing folks that have worked a job their entire life, had great benefits, want to keep those benefits most often because they have a spouse that is not retirement age yet
Sure.
or not ready to retire. And needs those health benefits.
Sure.
So it's really designed around making sure that folks can keep those benefits under Cobra for that 6 months, that year, that
Right.
18 months while they wait for their spouse to
Because
catch up
right
to them
now
with
the only
Medicare
option is
age.
they have to continue to be actively employed.
Actively
Okay.
employed or purchase an ACA plan at a very high cost due to their age. There are a couple other options for those folks, but none of them are particularly appealing.
Okay.
Even as simple as I'm retiring in August and I don't want to restart with a brand new Medicare
Yeah.
deductible
Yeah.
if I go on to Medicare. So just try to not penalize those folks that have worked their entire career, had good benefits, and want to keep them for that few more months.
Got it. I did get a text that it was difficult to hear you, Chaylin. So just a reminder, you gotta eat the mic. You gotta
Hello?
eat the mic. Okay, so that's kind of information from the Hill. What's going out there legislation
Yeah.
speaking, things that you may not have you won't have your clients ask about or be affected by tomorrow, but things that as an expert, as an advisor, you kind of need to be able to take a step back from your business and look at the big picture.
Absolutely. Well, and you always have that opportunity to reach out to your congressman, reach out to your senator, and offer that feedback of, hey, I would really love to see you support this bill. Would really love to see you voted out of committee. Knowing what committees your congresspeople are on, knowing where they fit in the legislative process can be really important. And even in Congress with 435 congressmen, one vote can mean the difference of something actually seeing the floor, actually seeing debate, actually getting into the public discourse.
I love it. Let's talk about my favorite segment. So
Okay.
let's get into the rumor has it. And this one's still I'm not going to say politically driven, but capital driven, right?
Yeah, I would
driven
say so.
driven in DC. Let's talk a little bit about rumor has it. The only one I remember you came into my office last Friday
Mhm.
and you said the HHS budget has been leaked. We have it. I have it in my hands. I don't know what happened.
Yeah.
So it's not maybe like the same thing as I don't know, battle plans or missile strikes being leaked or anything like that. That
Sure.
would be outrageous. But this is something that, again, we haven't seen in the past. We get a sneak peek of what's going on. Tell me a little bit, what happened on Friday?
Yeah, so I'm a big believer that nothing happens by accident,
I
even
love
things that appear
conspiracies.
accidental.
Everybody grab
But-
your tinfoil hats.
But yeah, so we did see a draft budget for HHS leaked from the Office of Management and Budget. Now, I guess the one thing I would clarify with this is a draft budget. Each department drafts up what they would like their budget to look like. That still has to go to Congress. It still has to go through the budget process.
So it's not finalized.
Still has to be voted on, far from final. But this is just HHS, Department of Health and Human Services, saying, if we got our way, this is what our budget would look like. Now, about 3 weeks ago, RFK announced that HHS would be going through a major restructuring. They would be combining and shifting a bunch of departments to go from 28 departments down to 15, moving programs under other departments, getting rid of some programs, things like that. So the big reason that this was such news was it gave us the first real tangible look at what this reorganization was going to look like.
Okay.
What programs were getting cut, what programs were being shifted where, all of those things. A couple of the big points to note, the 340B program, the low-income drug discount program. Tons in the news about 340B. It has been wildly debated and even litigated on how the 340B program is managed, on how
Is this LIS?
hospitals...
Would the public know that it's LIS, or is that still different?
No, so this is totally different.
Totally different
so
from LIS.
340B
Okay.
is just the program that allows hospitals to purchase drugs at a significant discount.
Got it.
The purpose of the program, the idea behind it was I can buy Humira for a 60% discount,
Mm-hmm.
and I can pass those savings on to predominantly low income, predominantly uninsured individuals
Okay.
so they can afford to take their medication.
Sure.
But what is being litigated both in the actual court and the court of public opinion is how much some hospitals are using that 340B program to simply pad their bottom line.
Yeah, which would
Because
never happen because money
no,
doesn't do that to people.
because there's really no good mechanism to monitor. We bought this drug at 340B prices, but we also bought a bunch of it at regular prices.
Mm-hmm.
Are we providing the same amount that we bought at that lower price
Right.
to low income
Yeah. The
individuals?
what next?
Or are we just sending that on to our fully insured customers
Sure.
and collecting the difference?
Okay.
So there's a lot of discussion about that. So 340B running under CMS could be a big change, could be an opportunity to see some changes in that. CMS has a lot of discretionary budget line items where they could create demonstration programs, create,
Mm-hmm.
through the Innovation Center, they could come up with some kind of model to amend 340B. But that's not all.
Mm-hmm.
There was a lot in this budget. So among the other things, we saw the Administration for Community Living that houses a lot of outreach programs and things like that. We knew that was going to be abolished as a department and that some elements of it would be shifted under other departments within CMS, within HHS. But I think one of the big ones, one of the big shockers was the draft budget included no funding and would result in the ending of the SHIP program.
Which, when you came into my office, I'm going to steal your language and pretend like I thought of this. Like, oh my gosh, disclaimers.
Yeah, absolutely. So what happens to our disclaimer? Because
Mm-hmm.
I think that's a really good point for agents to know, because think about the CMS rulemaking process and how long that takes.
Mm-hmm.
Think about how long Congress takes to get anything done.
Mm-hmm.
So what happens if Congress doesn't pass the budget until September? And we still have a disclaimer that we have to read that mentions SHIP, which no longer exists. So it could be a mess.
Could be a mess. But I think, again, I know, and Pam says I'm not sad about that. I think, too, like, it's kind of continuing to point to what I think this administration has done in the past, which is pointing towards, inadvertently, I don't think they're actively doing this, but like the need for agents. Like they're doing this with the ACA, eliminating a lot of the budget for the navigators.
Yep.
They're doing it a lot with, again, just kind of pointing towards the need for private
industry.
Private industry to kind of
solutions.
take and that's what we are as insurance agents, is being the solution to this advising to access to care and things like that.
Well, and I think a lot of it has to do with, again, there's a lot of talk about looking for fraud, waste, and abuse.
Right.
And I don't, I wouldn't necessarily, I would never accuse SHIP of being full of fraud, waste, and abuse. But what I can tell
Not
you
on a
is,
recorded public forum. Sure.
what I can tell you is they haven't provided an annual report to Congress since 2020.
Okay.
So that seems like an issue. But that being said, again, not the only things in that draft budget. The other big thing, that draft budget makes the assumption that ACA subsidies will not be extended. So when they're working on their programming, working on where they put money to fund the workflows within CMS and HHS, it's based on the assumption that ACA subsidies will end at the end of 2025. So is that insider information? Is that we have to do it that way until we know different?
Yeah.
We can speculate on that all day, but that's still pretty big news.
It's big news. It's not surprising. I guess it is a little surprising. It's with the Trump administration, because the Trump administration, from my understanding of the ACA, it didn't say the first round in 2016, Trump was saying we're ending ACA, we're putting something else, we're giving power back to the private entities. Yeah. This time around, he's not saying that. He's saying we're going to keep the ACA, but go through a significant facelift, significant restructure. We're going to keep this. We're going to keep this structure, but find other ways to fund it, find other ways to keep it going. So people, whenever that came out, really didn't know, okay, well, if you're going to keep this, how is it going to be funded? Because you haven't said that yet.
Absolutely.
So not surprising, but maybe clarifying is kind of what we're going
I think
towards.
It definitely gave us some sneak peeks into what policy priorities will be, because I think that's something we haven't seen yet from the current administration. Is we haven't seen a lot of, I guess, what I would call originated rulemaking. So there have been some rules come out, like the CMS final rule, which we'll talk about in a minute, and even like Part D redesign and some of those things. But most of those rules were started, the proposed rule was created by the late Biden administration
Sure.
before they left office. And then the Trump administration had to respond, had to take it through the process, had to finalize the rule. But there really haven't been very many rules in the healthcare space that originated with a Trump appointee and were taken through from proposal to final, all under the guise of the Trump administration. So we're really just seeing them get started on rulemaking.
Interesting. So you have it, guys. Rumor has it. And again, Pam saying, I'm assuming she's talking about SHIP, that they just don't provide the value. Certainly not the same value of like, it's like the accountability, right?
Yeah.
It's like, it's a lot easier to not provide value whenever you don't have to be accountable for that value. You're not being compensated for the value that you provide, such as somebody who is an insurance agent gets directly compensated for their value and need to make sure that we're reflecting ourselves in that way.
Well, and I think, you have a lot of, whether it's a lot of members of Congress, a lot of members of some of these think tanks or policy shops, a lot of misinterpretation of what the initial intended purpose of SHIP ever was.
Yeah.
SHIP was never intended to help people make plan selections.
Yeah.
It was intended to educate on how original Medicare enrollment works, help people sign up for other programs like LIS or Medicare savings programs. It was designed to educate them on how they could find a plan through Medicare.gov or other publicly available sources. But it was never, ever designed to walk a client through the process and actually help them shop for a plan.
Yeah.
It's not what SHIP was meant to do, but that's what a lot of people are trying to make it do.
Well, whenever it's in the disclaimer of like, go here for a plan slide. I mean, like that's what the disclaimer literally says it does. So that'll be interesting. Sherry, hello, Sherry. She says, we actually, okay, I can't see that far, have a local SHIP office that refers a lot of clients to our office. That's one good thing. But other than that, not too much positivity to say about them.
Yeah, I would say it varies drastically depending on where you are. You've got
zero
SHIP,
consistency.
Yeah, I mean, well, so I think that's the other thing. SHIP is a nationally funded program, but it's basically block grants that go to each state, and they fund their own state health insurance program. So like here in Missouri, it used to be called Claim. There's all sorts of different names for it around the country. And a lot of times it's block grants that go out to these other community organizations like your Voluntary Action Center, your Area Agency on Aging, one of these other community resources that then takes a person and puts them in that SHIP officer or SHIP counselor role and sends them through the training and all of that. So there are great SHIP counselors around the country that do work relationships with many agents that can send those referrals, provide that background information. And there's some that think agents are the worst things since sliced bread. And that's just part of it. You take the good with the bad, but we may not take any of it very soon.
You like that. Let's get into our final segment, which I would love to tell you it is final ruling.
Hey.
And the few minutes that we have left, I know we've actually, if you guys want a little bit more of a, not really a deep dive, because there's really not much to deep dive on, but Chaylin did post a video last week on our Senior Marketing Specialist YouTube page, kind of giving a brief overview of what we knew about the final ruling. But it bears to be repeated here, Chaylin. Again, take it away. What do we know since that final ruling was published?
Absolutely. So final rule was much anticipated this year. Obviously, a few big provisions we were very worried about, like the changes to submitting marketing and communications materials that would have resulted in thousands of hours of additional work time for CMS, as well as thousands of hours of work time for agents everywhere, and me specifically.
Yeah,
so
truly. That's what Chaylin does for fun. He just reads the final ruling while he's fishing and doing other stuff. Also, have you not that point? This is not for you. Are you going to be able to go turkey hunting this season?
I don't know if I am.
You don't know if you are.
So turkey season opened
in Missouri yesterday. Yeah.
Maybe this weekend.
Okay.
But I'm not sure.
I hope you get the chance to. I know that's kind of your escape. Maybe you can have some paperwork there while you're doing that to give yourself permission to do so. Sorry, go ahead. Final ruling.
No. Yeah, for sure. So anyway, like I said on the slide, what is not in the rule is way more
Mm-hmm.
important than what is. So that marketing provision struck out.
Oh.
The many of the other provisions that we were a little bit worried about, changes to some of the proposed changes to the prescription payment program,
Mm-hmm.
some of the proposed changes to what agents and brokers are required to say during an appointment,
Mm-hmm.
struck out. Honestly, the only handful of things that the Trump administration kept in the rule were some conforming amendments to the regulations to bring it up to speed with the Inflation Reduction Act.
Yep.
So just Inflation Reduction Act said this, they had to technically go through the rulemaking process to add that language to the Code of Federal Regulations.
All that
It
stuff.
was a lot of just editing and
Fancy stuff.
proofreading and making sure it said what it was supposed to
Sure,
say.
sure.
Really not even any major changes to some of the Medicaid provisions, some of the DSNP provisions. One of the things that was in there that, we haven't heard a ton about the Medicare prescription payment program. It was kind of a blip on the radar. Everyone was really worried about it, but the utilization hasn't been very high, hasn't been a huge thing. But one of the things they did finalize that was not in the proposal, but did make it to the final rule, was that people enrolled in the prescription payment program will stay enrolled in it if they roll over on the same plan next
Okay.
year.
So if they roll to a new plan, they'd have to
They would have to
re-enroll in it.
re-enroll.
But if they just kind of let it ride, they're
going to stay enrolled in the prescription payment program.
does
In the
the
past, they were
debt
going to have to re-enroll every year.
Okay, so with the debt, we may not know this yet, but if they had debt, because they're supposed to have all the debt paid by December 31st of
In
that
theory.
thing and that plan. So would the debt then continue if they didn't
Mhm.
get that done, roll over to the next year?
Yep.
Okay.
Yeah, the debt would roll over even if they voluntarily disenrolled.
Yes.
They would still owe that money.
Right.
The big thing for clients to realize is going to be, hey, if I owe $400 at the end of the year and I don't pay it, even if I want to stay enrolled in the plan, if I don't get that paid down, I'm going to end up disenrolled
Okay.
by
Sure.
February.
So again, this isn't about the M3P, MP3. Is it M3P? Anyways, not about that. But what it is, if I'm on United Healthcare, I rack up my debt. I have $400 at the end of the year. I'm still responsible to pay for. If I then enroll in a WellCare plan, does UHC have to eat that cost, or does that mean that debt doesn't follow me, right? Because it's administered
It does
by
follow
the carrier.
you, so they can pursue it under regular debt collection law.
But it would be UHC
It would be UHC
pursuing it, not my
pursuing
new
it.
Part
Not
D.
your new.
So you don't
debt doesn't
escape it by
transfer
changing
to the new
plans.
carrier. You don't escape it necessarily. Now that said, medical debt is relatively difficult to collect right now. Under the Biden administration, they altered the rules where medical debt can't be reported on credit reports. Some changes like that. So it's possible that some of that may be undone. But yeah, at the end of the day, a lot of carriers are going to end up eating that cost. Now, again, right now it's a pretty small number of people who have even opted into the payment program.
Sure.
So it's not a huge risk to carriers yet.
Fun to talk about. A topic that people can easily get riled up, myself included.
Absolutely.
But just not utilized to a point where we're really seeing the full effects of it.
Yeah, I would be really interested to hear, say like Q3 this year from some of the carriers, what utilization looks like, what kind of bad debt they're carrying.
Sure.
Not that I expect they'll be willing to share that, but that's what I would be interested to hear.
Fair. So guys, before we close up for today, there is so much more to talk about. This is, again, I try to keep these to less than 30-minute segments. There's a million things to talk about, but good news for you, Chaylin and I have actually been asked to return, get the band back together with Ted Sims over at AIMC Integrity to do a webinar. If you guys remember last year around June or July, we actually started doing a webinar. It ended up being supposed to be like one or two times. We ended up doing it like 4 or 5 times. Yeah. Throughout leading up to AEP, talking about the disruptions in the Medicare community. Now, we know there's a disruption every single year. We know there's things, but this is the second year in a row that we're expecting some of the largest shopping rates from AEP. Yeah. Last year, the shopping rates were insane. 2026, a lot of agents are like, I think you put it best. Either you are... A lot of agents were chasing their tail, I think one of the words that you used, trying to keep on their book of business, while other agents had the biggest growth years they've ever had. It's hard to imagine doing that again. But guys, we're going to have to do that again. And
I agree.
Today, Chaylin and I will be joining Ted from Integrity and Chris from Nice Lawson Flemings, our partners up there in the Northeast, or kind of the northwest, east. It's still east, but not the northeast. Anyways, over in Philly, to be talking a lot about kind of what are we going to see throughout the rest of 2025, what we're going to see in 2026 AEP, and then
Yeah.
solutions for that. So if you want to sign up for that webinar, just go to our page, smsteam.net, click on our events tab, and there is a link to register for that webinar there. It is not going to be recorded, and it will not be sent out afterwards. We don't want to have to run it through compliance, and then knowing if it's anything like it was last year,
it's going to change.
It's different every time we do it. So make sure you attend that. Lots of really good information, lots of different perspectives. You'll have our perspective, and I saw some Fleming's, and of course Integrity's on there to go over like what the heck is going on this year.
Another big year in the books, I think, for sure. You know, it's so funny because we've talked a lot about like med sup rate increases and things like that, and how the new normal is double digits, and how that's the way it's going to be. I think we've really got to get used to Medicare Advantage being the same way. Historically, we were at like 12 to 15% shopping and switching. Now we're sitting right at or above 20%. I think that shopping and switching rate is going to remain high the next several years and be a little more of the new normal instead of this crazy blip on the map.
Well, and talking about like how do you have your clients handle that, right?
Absolutely.
Deaf Research did some really interesting studies last year that talked about clients who were within the first 3 years of aging onto Medicare were the least loyal, both to a brand and to the agent, because they're used to this chaos. They haven't been with a carrier long enough to develop loyalty, or with an agent long enough to develop loyalty. So your clients who've been on a plan for 10 years or 7 to 10 years, they're okay writing out some ways. They're okay saying like, I understand my plan's different, but like they've done me well so far, I'm going to hang it out, compared to those new ones that are like, let me jump ship. I need somebody to find a better plan for me.
You got to look at it too. Someone turns 65, obviously if they were on the ACA, they've shopped for health insurance before, but for a good half of your clients, this is the first time they've had a choice. They could choose between an HSA high deductible plan and a PPO. That's the only choice they've ever had in their working life up to now. So all of a sudden they've got, on average nationwide, over 40 plan choices.
That's wild.
It's really, really tough to keep folks engaged.
What a great job security for us agents.
Absolutely.
Right? It's great to be in the industry. It's great to be helping people find access to healthcare. Let's save this. We're going to talk about this again today at 2 o'clock Central Standard Time. So make sure you watch that. Again, go to smsteam.net, click on our events tab to register for that webinar. Guys, appreciate you all hanging out with us today. Again, and really always enjoy when I get to have Chaylin on, because you don't know how many times during Cafe where I said, well, Chaylin told me this, Chaylin told me that. So getting to hear it straight from this horse's mouth. Appreciate you guys. So until 2 o'clock, have fun,